Next, I would like to invite Dr. Nihal to do his presentation. Before that, I would like to give a description about his profile. Dr. Nihal has obtained his secondary education at St. Thomas College, Mount Everett. He entered National Sliva University, Japan on Japanese government scholarship for agriculture. Then entered National University of Osaka Medical School, and after graduation, interned in general surgery and anesthesia. Then he joined the faculty of the University of Hawaii School of Medicine as clinical assistant professor while specializing in obstetrics and gynecology. Then he earned an master's degree in public health, focusing on maternal and child health under United States federal grant. Subsequently, he joined the faculty of Stanford University Medical School, California, as a research fellow and clinical assistant professor, and subspecialized in maternal fetal medicine, further specializing in prenatal genetic diagnosis and fetal surgery, and was invited to present his research findings at the annual Congress meeting of the American College of Obstetrics and Gynecology. He introduced the use of Magnesium sulfate in obstetrics in Sri Lanka at the invitation of Sri Lanka College of Obstetrics and Gynecology at their annual meeting in 1994. He was also head of maternal fetal medicine at hospitals in South India for 9 years. He is a fellow of the American College of Obstetrics and Gynecology, diplomat of the American Board of Obstetrics and Gynecology. He has medical licenses in 4 countries and has been on the faculty of 3 universities and has lectured extensively. He is also the founder member of the American College of Health Sciences, which has subsequently become INHS. Not only that, he is also a national champion in the 1,500 meters wild school ball and also represented Sri Lanka at the Olympic Games in 1964 in Japan. And he is also an accomplished pianist. So I would now like to invite Dr. Nihal De Silva to do his presentation on contemporary issues in managing obstetrical and gynecological emergencies. Over to you, sir.
Thank you very much for that nice introduction. I'm sorry there's no piano here, or I'll play something. I've got a bad time slot for a speech because it's before lunchtime and you have already been sitting for about 2 hours. So if you don't mind, you can stand a little bit and get your circulation going, because I don't want you to fall asleep during my talk. All right, thank you. And we can also do this thing they do about, breathing everybody out. That exercises your back a little bit also. I'll try to finish by 12:30, which is the official lunchtime. We are running behind time. Thank you very much for bearing with us. I'm going to talk about obstetrical emergencies, and I'm not going to talk about gynecological emergencies because that comes under general surgery more or less. Now, emergencies in obstetrics is a little bit different from the kind of emergencies that the 2 previous speakers spoke about. Now, according to Western tradition, this is the guy that causes most of the problems. They seem to come from nowhere and deliver these packages that we call babies. And we have to be careful. It's like crossing the road. You might suddenly run into an emergency. So, maybe we should have ladies wear a board like this when they are pregnant and they walk around. You might get a little bit more respect than what you get now. Okay, let's talk about obstetrical emergencies and their relevance. Being that I have a public health background, I try to show the clinical relevance of certain observations that we do in terms of statistics and other observations. We have known obstetrical emergencies for centuries. They're nothing new. Other kinds of trauma are very new. People falling off, buildings that are 100 stories high, and people racing on the road at 100 miles per hour, which we did not have 50 years ago. Obstetrical emergencies we have had for centuries. And that's one of the reasons why childbirth moved to a hospital. Some emergencies are somewhat predictable. So they may not be real emergencies, but we consider them as such. And others become emergencies due to neglect or delay. And this neglect or delay is either intentional or most of the time unintentional. Now, the final purpose of addressing obstetrical emergencies is to reduce maternal mortality and morbidity, and also fetal mortality and morbidity. So we have a package here of 2 lives. Even in the 21st century, there is too much of a price being paid by mothers in bringing forth children into this world. This is quite a sad statement, but it is in fact a true statement. The price being paid is different according to the region of the world or country, or sometimes even within a country. Human history has shown that needless deaths can be prevented, sometimes not with expensive technology and gadgetry, but sometimes with simple education. Now, if you look at a map of the world and see where most of these so-called emergencies or maternal deaths take place, the brown and the red areas of the world are where most of the problems are. You can see that the darker brownish colors are in Africa and Asia. And their deaths, the maternal mortality, calculated on the basis of 100,000 new births, is over 1,000 in some countries. And if you look at the list of the countries, according to the WHO, Chad is number 1 in terms of the worst outcomes. Number 1 does not mean the best here. Number 1 means the worst. And they have figures of 1,100 mothers dying for every 100,000 children born. And the list goes down. And Afghanistan was not included in these figures because it was at war, and figures were not very accurate. And if you think Afghanistan is bad with 1,400, Sudan, really South Sudan, which is the newest country on the globe, it is 2,054. So these figures are in 2006. Now if you look at where Sri Lanka is located, it's number 118 from the other end, and our rate is 35 maternal deaths per 100,000 live births. We are doing a little bit better than China. If you look at Thailand, we are doing much better than Thailand. Malaysia is a little bit ahead of us. The figures on your right are the number of maternal deaths per 100,000 live births. Now if you take a look at India, which is our biggest neighbor, they have a population of 1.1, I think nowadays about 1.2 billion, and they have 56,000 maternal deaths per year, which averages out to 156 mothers dying in childbirth every day. Sri Lanka has a population of 21 million. We have 1 maternal death every 3 months. I think these are very good figures. Of course, we can improve on them a lot more. If you look at the better end of the scale, 183, which is really number one, Estonia, has only 2 maternal deaths per 100,000 live births. However, some of these countries are small in size and have very small populations. So the figures may look good, but they really have to work with a different set of better circumstances than it is. Now, I got a lot of my experience in the USA, as did Dr. Leonard. What's the situation in the USA? Supposedly the most powerful country in the world. Well, their maternal death was 9.1 per 100,000, somewhere till about the middle of the 1980s. That's when I was there. And it gradually rose to 14 in 2000, and it's now hovering at about 24. Remember, Sri Lanka is 35. So the rate has gone up recently. And this has been traced to the fact that there has been a lot of immigration, massive immigration from African countries, from Middle Eastern countries, and people really haven't changed their behavior towards childbirth and pregnancy, and they tend to delay seeking treatment and even shy away from treatment. Also within the US, there is this freedom now of being able to give birth at home and introduce various health factors, and they get to the hospital a little bit too late when trouble comes, and therefore they add to the figures and they look bad. Another recent theory to explain this is that it all started happening since I left the USA. Give some thought, there might be some truth in that. Okay, this is kind of a difficult graph to follow. That big line you can see shows the points of maternal mortality in some of the bad countries like Afghanistan and Chad and Liberia and Tanzania and all that. And if you look at the very bottom to the right, you can see that the dots are almost close to zero. Those are the better countries. But this is a picture of the situation in Sweden. Now, you can see that what's happening now in some of these countries, bad countries as it were, was what was happening in Sweden about maybe the 1830s, 1820s. So we are about maybe 100 years behind what some of the European countries were experiencing. So we have a lot of room for improvement. Now these are the Sri Lankan figures. We can see that in 2004 our figures were 44 per 100,000 live births. In 2008 it came down to 39. In January of 2010 it has come down to 35. Now more than 75% of maternal deaths worldwide, and these are events which we usually call emergencies, there are 5 direct causes according to the WHO publications. And you can see that the top 5 are: number 1, unsafe abortion; 2, severe bleeding from childbirth; infections from childbirth; preeclampsia; obstructed labor; and other direct causes. Now, they total about 75% of all known maternal deaths. On analysis of these 5 different causes, 3 factors emerge. First of all, knowledge of the availability of services by the mother or the family. Number 2, delay in deciding to access available services. Sometimes they know that the service is there, but they're shy, or for some reason they don't want to go. Number 3 is the quality of the services at these institutions. So people have analyzed these factors, and they have looked at different human factors involved. They have found that socioeconomic and cultural and educational factors play a large role in this. And therefore you can see why things are bad in Africa and some of the Middle Eastern and other quote, bad countries, because their educational levels are pretty low. Facilities are not easy to find or sometimes non-existent over long stretches of land. And the quality of the care at the facilities may not be very good either. And then if you further study the phases of delay, the decision to seek care is number one delay, identifying and reaching the medical facility is the second, and once you get there, there is readily available quality services. Deadly delay. Delay in decision to seek care, delay in reaching care, delay in receiving care. These three phases of delay rarely operate in isolation. And these delays leading to maternal death are often multifactorial. Now, Dr. Leonard talked about what happens during the first hour of the initial visit of a trauma patient. In obstetrical situations, we can, in a way, know what's happening because we have adequate human history to tell us how pregnancies behave or misbehave. So these issues here are not really clinical in a way, but more social and maybe economic, and maybe some political decisions rather than clinical decisions. Here's another way of looking at these factors, and you see how the arrows are working. Now, this is dated March 2014, which is just 3 months ago. It's the committee opinion of the American College of Obstetricians and Gynecologists. And you can see that it replaces the opinion of April 2011. You see that they have changed or maybe upgraded or revised certain opinions and policies in 3 years. Now this is something very good about America. They always keep updating new information and making it available to the professionals. Otherwise that information is useless. So we are sent all the latest information adequately so that we can upgrade our knowledge. Now this is a committee on patient safety and quality improvement. And they came out with a document saying how to prepare for clinical emergencies in obstetrics and gynecology. And they listed some tools for managing clinical emergencies in obstetrics. Now some of these tools are the very same tools that Dr. Leonard talked about. Availability of appropriate emergency supplies. When somebody comes, if you're not prepared for them, you can't handle them. Okay, so we have to make sure that we have all our equipment ready. And in the United States, we call it a crash cart. I don't know what they call it in some other countries, but it's a very common term in the emergency room in the United States, crash cart. And also in obstetrical studies. Then, development of a rapid response team. When certain types of trauma come to the emergency room, you have a team within the staff working in the emergency room to handle certain kinds of trauma. It evolves over time that some guys are interested in abdominal trauma, some guys are interested in head trauma, and they kind of develop little teams, and they kind of work as a team. And you have to have certain protocols to follow. If you have 10 members of the team and they're all kicking in different directions, you will never get a goal. So you have to make sure that you follow a common pattern of behavior or follow the same instructions. And certain triggers, certain clinical triggers, you can call them signs and symptoms, should give you off as to what is going on. So you have to have a good sense of clinical judgment. And this is very important. You have to have standard communication. I think the previous presenters talked about that too. You have to have a common language when you're talking to your other team members. And sometimes we use abbreviations, sometimes we use, short phrases, and sometimes we just use one word, and people get the message. But if you're an outsider in the team, you don't get the message, and it really is disturbing. There are certain things that happen even in regular wards. For example, in the labor room, sometimes I have had experiences where I call for a certain pair of faucets to give to the baby. And the faucets come in all different names. And I'll say, give me a look up, and then some new nurses say, because they're not used to it. It's not their fault, it's just that we have not developed enough of a communication system. So it's very important as a team when we are dealing with trauma that action has to be rapid, that we have our own language. It's not to feel important, it's to make sure that we have adequate efficiency. And then another important thing is to have frequent simulations and drills. When I went to the United States in 1973, this was all foreign to me, but they really did it very well. Every week they rehearsed some kind of an emergency. Now, if you look at pregnancies and emergencies from pregnancies, you can look at them as conditions that would be unique to pregnancy, like preeclampsia and eclampsia, amniotic fluid embolism. These are the big ones. They can be related to bleeding in pregnancy. We have trauma to the pregnant uterus. We have abruptions, placenta previa, basal previa. We have disseminated intravascular coagulopathy. Then we have other problems that are related to the physics of labor and delivery. Cord prolapse, bridge presentation, shoulder dystocia, uterine rupture, cephalopelvic disproportion. The outcome of most of these will depend on when and where the pathology is detected. Sometimes it can be detected in a location where adequate treatment cannot be supplied. So you have to be knowledgeable in what the best that you can do is, and then in the meantime make arrangements for transfer to an adequate facility. And remember, the facility should not only look after the mother, but also be able to look after the newborn. And for the purpose of this presentation, we will assume that the pregnancy is more than 20 weeks. The most serious of the emergencies less than 20 weeks would be ectopic pregnancy and incompetent cervix. Incompetent cervix usually does not affect the mother negatively, so it's not really a true emergency, although it's a sad emergency. Ectopic pregnancy can be taken care of by general surgeons, and nowadays it's an easy diagnosis compared to what it was 25 years ago. Now, the outcome in emergency will depend on the location where the pathology is detected, what I said before. And a hospital setting will probably give the best results. Obstetric emergencies are seen during pregnancy, during labor, and postpartum. So there are certain metabolic and physiologic conditions that are unique to human pregnancy that end up as emergencies. Now you can see that I'm moving from figures relating to public health more to clinical material, and I'm doing this also with the specific purpose of being able to relate to most of our audience today. I think our audience consists of a lot of nursing students. I see a lot of nurses in uniform. And I think that maybe these clinical aspects I'm going to talk about would be of some use. Preeclampsia and eclampsia is one of these conditions. I call it metabolic and physiologic because there is no other way I can classify them. Now this is a condition that usually is gradual in onset, but begins to progress with time and give us new signs and symptoms as we go along. Now this thing called amniotic fluid embolism, on the contrary, is rapid, meaning it happens within minutes. There you have large and rapid infusion of amniotic fluid into the maternal circulation. And it's considered a massive anaphylactic reaction, these days. And it's a sudden onset, no advanced signs and symptoms, and it's usually something that happens during labor. And if it is not treated within minutes of onset, it's usually fatal. And it is definitely fatal if it happens outside a hospital setting. Now, preeclampsia is pregnancy complicated by hypertension, proteinuria, and edema. I think all people in the medical field know this. Now, I'm going to talk about pregnancies that are over 20 weeks with hypertension. Now, this happens in about 10% of human pregnancies all over the world. Preeclampsia, which may lead to eclampsia. If you talk about 10% of the world's pregnancies being affected with this, it's a large number. It's a large number. Management has increased quite a bit over the last 30 or 40 years, so our results are a lot better. Now, this condition is not found in any other animal species, so we can't do experiments to get more information. So therefore, we cannot do any research. And there is no known cure except to deliver the pregnancy. But if you want to retain the pregnancy to gain some time, to make sure the fetus matures, then you have to be well informed in terms of judicious management. Now, preeclampsia is divided broadly into two categories, mild and severe. Now, preeclampsia is also the precursor to what is called eclampsia. Now, eclampsia is pregnancy-related seizures or fits. I think the British Commonwealth yet uses the word fits, but in the United States we use the word seizures. Eclampsia is also sudden, but most of the time there are enough signs and symptoms that show that it is on its way. It can be severe and more devastating if the preeclampsia starts early in the pregnancy, because there is more time for eclampsia to develop. This is more common in first-time pregnancies. So this is information that is handy for people who are managing preeclampsia, especially in a non-hospital setting. You know, if you have pregnant mothers who are hypertensive, then you treat them with a lot of respect. Pregnant teens and women over 40 are also at increased risk. Now, maternal complications of neglected preeclampsia or eclampsia are liver damage, kidney failure, bleeding and clotting disorders, and HELP syndrome. HELP stands for hemolysis, elevated liver enzymes, and low platelets, together with, of course, proteinuria, hypertension, and edema. It's kind of a end-stage multi-organ failure in pregnancy, and it's pretty serious and it needs to be dealt with immediately. You can't buy time with HELP syndrome. Mild eclampsia is basically initially diagnosed because of elevated blood pressures. And it has to have a certain quantity of proteinuria, which means you have to measure it. However, nowadays we have dipsticks which give us a rough idea of how much protein you are using. Now, Edema can be preceded with rapid weight gain, or sometimes you can just see plain edema with no special weight gain. Now there are other things like oliguria. In preeclampsia there is no oliguria, you have normal urine output. And there are no other easily detectable associated symptoms. With severe preeclampsia you do, but not with mild preeclampsia. And most of the time the labs are normal and the fetus is growing normal. Therefore, should mothers be admitted and be kept in hospital? It will depend, I think, on the resources of the community, but a lot of mothers prefer to be at home, they prefer to be ambulatory, provided, of course, they can be monitored adequately. And I think Sri Lanka has a pretty good system of nurses visiting mothers who are pregnant and keeping tabs and things like that, which the United States, for example, does not have. Severe preeclampsia is when the blood pressure is really high and proteinuria is more than 5 grams in 24 hours, and there's obvious edema, very little urine, and you have headaches and other kinds of visual disturbances, abdominal pain, pulmonary edema, and you start frothing in the mouth. All the labs become bad. If you neglect it, it will be HELLP syndrome. And IUGR is usually present depending on the stage of pregnancy you're at. Now, this is imminent eclampsia, or sometimes without getting all these different things, eclampsia can hit you. Seizures with preeclampsia. It has a 2% mortality rate in hospitals. Now, all over the world, most pregnant mothers, especially towards the end, are in the hospital in the so-called developing countries and developed countries. So, the mortality rate is not that high nowadays, but it used to be. The usual cause of bleeding or death in the mothers is from intracranial bleeding. The patient has to be transferred to a hospital to be better managed. Before the fetus attains fetal lung maturity, preeclampsia can be managed long-term in a hospital setting with very specific behavior patterns that the mother has to kind of undergo. Mother has to be lying down on the left lateral side, eat an adequate amount of protein, monitor the fetus to see that it's growing adequately. But after fetal lung maturity is established, then if you have preeclampsia, it's probably better to get the fetus delivered while you don't let the preeclampsia get worse. Now, rest, antihypertensive medications, corticosteroids to help accelerate fetal lung maturity. Tocolytics, controversial, but sometimes can be used to keep the uterus quiet to gain a little bit more time, especially if you want to get about 48 hours after giving steroids to the fetus or to the mother. And also sometimes you can use anticonvulsant medications. Hypertension can be treated either orally or with intravenous medications, the most common being labetalol or nifedipine or hydralazine. Nowadays, intravenous magnesium sulfate is the drug of choice. And it's a rapid onset kind of medicine, it's easily reversible, it's relatively non-toxic, it gives a lot of neonatal protection, and it's inexpensive. Previously, we used a lot of medicines called dilantin and Valium, which is yet used in some countries, unfortunately. These do help with the seizures, however, they affect the fetus very badly, and also the mother. But because we had no choice in the past, that's what we did. Now, use of magnesium in obstetrics in Sri Lanka. This is to boast about myself a little bit, if you don't mind listening. Magnesium sulfate has been used in the United States since about 1910. It was used mostly intramuscularly, but since about the 1960s it has been used intravenously. It was not used commonly in Europe till about the 1980s, where dilantin and Valium was the drug of choice. In 1994, I was invited to share my experience with the use of magnesium sulfate here in Sri Lanka. I came and gave a couple of lectures at their annual meeting. I found that Valium and dilantin were the drugs of choice here. In fact, during the talk and after the talk, people were questioning me about the toxicity of magnesium. They thought it was really a very poisonous medication. Remember, all medications are poisonous, but magnesium sulfate is relatively non-toxic compared to dilantin and Valium. Now magnesium sulfate is being used commonly in most of the European countries, including the UK. Now, this will be a side story. I'm told that an examination by the Royal College of England, or anesthesiologist, a Sri Lankan anesthesiologist, when questioned about preeclampsia, he gave them the answer saying, "We are using magnesium sulfate," much to the surprise of the British doctors. And he was asked where he learned it from, and he said, "The Americans." He did mention my name, I'm very upset about that. He should have failed, I think, but anyway, he passed with flying colors. Okay, next group of emergencies. Now, these are things that we see consistently, and these are things that have been known for centuries. So they are emergencies of sorts, but we know a lot about them and how to manage them. Bridge presentation, CPD. These are not sudden events. You can see it coming. So really they may not be emergencies. Cord prolapse, shoulder dystocia, uterine rupture are true emergencies. They hit you from nowhere, usually sudden and unexpected. And usually needs more manpower, more equipment, and usually more anesthesia. So that's where a team will be helpful. We'll look at some of these things very quickly, although I think most of you know what they are. Umbilical cord prolapse. Here's a picture made in 1792. All hand drawn. And here's what we see today with computer technology. This is when the umbilical cord suddenly drops out of the root canal. It happens in about 1% of pregnancies at term, but it could happen more frequently before term. Can happen before the onset of labor, and you can detect some of this by modern ultrasound technology, so you have an idea that there is an umbilical cord in the wrong position. You can change quite a bit too. So unless the membranes are ruptured and water is leaking, the cord may reposition itself. It's usually very common if the baby is not coming out head first. More common if there is more fluid, if there is a multiple pregnancy, if the umbilical cord happens to be longer than usual, and if the umbilical cord is inserted on the placenta marginally and not centrally, which makes it have a little bit of extra length kind of thing. Now, it can happen with spontaneous rupture of membranes or with artificial rupture of membranes. Spontaneous rupture you can't predict. Artificial rupture is what we do. So we need to be aware of what we do, make sure we palpate adequately, or we use ultrasound nowadays to know that the cord is not in the way. So always check before AROM. And you can do this very easily nowadays with colored objects. Now, if you see this cord which is prolapsed into the birth canal or into the vagina, you want to make sure it has a pulse. If it does not have a pulse, usually means that the baby has died. Not necessarily, but most of the time. Again, you have to check and see that the fetal heartbeat is there. Sometimes palpating pulse is not very easy. You need to have a lot of experience because you're palpating things in a very different location than you're used to. It's not like checking a pulse here on your arm. Now, there are a couple of things that you can do in this so-called emergency. Basically, if the mother is flat, put her head down and lift her legs. Let things flow the other way. That might help in taking the pressure off the cord from the fetal head. You can manually push the head away from the cord. Don't try to push the cord, push just the head. Now, very interestingly, there are some other things you can do reported in various parts of the world. This is not usually used in the United States very much. You can fill the bladder, and that will lift the head up. We all know that if a labor is going slowly and the bladder is full, it prevents the head from engaging and head coming down, so we are using the reverse principle. Also, you have to stop labor with active labor because with labor, with the contractions, the head is getting pushed down and squeezing the cord. Do not try to reposition the cord. Give the mother adequate oxygen. And you have to do immediate surgery. Now, shoulder dystocia. This is a real big one. Truly big. Because that's when the big shoulders don't come out after the head has come out of the introits, or what they call the opening of the birth canal. The head comes out, nothing more. And within seconds you feel the head getting pinkish, purplish, and blue. Because it's basically suffocating at the neck. Blood can't go back. This is a true obstetrical emergency. It's a real emergency. Okay, if you look at the arrows here, you see that the pelvis is contracted this way, the passage gets blocked. Now, it's due to a narrow pelvic opening, or else, more frequently, too large a baby. Or it's a combination of both. Please note the fetal clavicle, fetal shoulder bone. I have drawn a little red line there for you to see. That area is critical because that's the area where a lot of nerves from the fetal neck go down the fetal arm. And in trying to manipulate the shoulder to come out, we sometimes cause a lot of injury to the fetal arm or the hand. It's called palsy, various palsies depending on the extent of the nerve damage. This is another way of looking at it. The fetus looking the other way. The shoulder is impacted against the pubic symphysis bone. Note the position of the posterior shoulder and the coccyx. The posterior shoulder is the shoulder that's below there, and also you can see the coccyx which is kind of turned up a little bit. In this picture, there seems to be enough room there, but in real life the room is very little. Now, one of the early signs of this happening is when you see the head coming down with a contraction, and once the uterus relaxes, they go back. It doesn't come out of the birth canal yet. It comes down, goes back. Comes down, goes back. That's called the turtle sign. And if you see that, that's a little warning that something might go wrong. And with neglect of this sign, and if the fetus, if the shoulder doesn't get caught, the umbilical cord also gets compressed real bad. And then you have fetal demise. Now, brachial plexus injuries of different degrees, here they are, all kinds of names we have for it. But the baby can also have fetal hypoxia, which could lead to cerebral palsy, and the baby will also die. And the mother, on top of that, can end up having what is called postpartum hemorrhage, because the baby has been too big, has distended the uterus too much, and the uterus has got tired from a long labor, and after the baby is delivered and the placenta is delivered, it doesn't have enough power to squeeze on itself and stop bleeding. So these are some of the things that you have to be anticipating. There are lots of risk factors, such as diabetes in the mother, which causes fetal macrosomia, and also the mother being obese. Usually there's a combination of factors. It happens in about 1% of vaginal deliveries, and look at this, it says recurrence rates are relatively high. So, if you have this happen once, the mother should be informed that she has to tell the future child helpers that this is something that happened previously. Because it could happen again, because probably the mother's pelvis is narrow, or she's on the obese side, or she has diabetes. Alright, now a number of maneuvers are sequentially performed to try and get this shoulder out. First is called the McRoberts maneuver, and that's where you basically fold the mother in two. You get a legs to go up this way. That's supposed to broaden the pelvis, and usually it might let the shoulder slip out. Somebody can put pressure over here, not at the fundus, but right over here. Press down. It makes the pelvis go wider a little bit, and the baby's shoulder might slip out. No fundal pressure. Now, these are things that we need to know, because instinctively when the head gets stuck and nothing happens, an unknown person on the team will come and push fundal. You only jam the shoulder a little bit more. Now, these two maneuvers are effective in about 40 to 45% of the cases, which is good. We are kind of getting ourselves out of trouble half the time. Now there's another maneuver called the Woods corkscrew maneuver. What you do is you try to turn the baby. Don't pull it out. Put your hand into the baby's and twist the baby. And then the baby is twisting, it sometimes finds an adequate diameter and slips out. It works a lot. I have done it so many times myself. I think it's very effective. Very effective. On top of that, somebody is giving suprapubic pressure, and also the mother is in the McRoberts position. So it's very helpful. Very helpful. Remember, if you are in a bind here right now, the baby is half out. There is another method that has been described. That's where, when the shoulder is not coming out, you force your hand posteriorly, grab the baby's arm posteriorly, and pull the arm. It's a little bit more traumatic, you might cause a little bit of damage, but not much of nerve damage. And it's also going to work if the first three maneuvers don't work too well. Another method is basically the McRoberts maneuver, but done the opposite way. You have the mother go on all fours, just like the animal. Seems to widen the pelvis a little bit, and the baby might slip out. Okay. Now there's a thing called the Zavanelli maneuver, which is not too old, it's about maybe 15 or 20 years ago that it was described, where you basically push the head back forcibly and do a cesarean section. Now obviously for that you have to be in a hospital, you probably have to have good anesthesia standby, and you have to be in an operative room setting. That hasn't been described, it has been successful. And it has not caused any damage, nerve damage. Now, there's another maneuver that has been used effectively, or should have been used frequently, mostly in the African countries, where they basically fracture the baby's clavicle. The picture that I showed you before. The moment you fracture the clavicle, the shoulder collapses, you lose shoulder breadth by about 4 to 5 centimeters. It just slips up. Now, usually clavicular fracture does not cause nerve damage, but if you don't do it properly, it can. It's usually not done in the United States. But in countries where it is done, they don't show much nerve damage. But trying to pull the fetus out forcibly is what causes nerve damage. Another one that is being used in African countries quite a lot is syncytial, where you cut the bone right in the middle. And then gap there, very soft tissue, cutting with a scalpel, and then it is opened up. Unfortunately, after you do it, the mother can't walk for about a couple of weeks. She has to be bound and has to let the steel over or the metal clips and make it come together. The mother has to be mobile for some time. So it's not again something that is practiced commonly or practiced in the United States. I've never really seen it being done. But it's done in some of the African countries, I'm sure. Okay, now, this is the baby is trying to come out or has just come out. Now we're going to look at what are the problems that happens after the baby is born. This is after delivery of the fetus. It is the second stage of labor, but before the delivery of the placenta. So, after the pregnancy is inside, so that's the third stage. One of the things that happens is uterine inversion. The uterus just turns inside out. One is that the placenta is stuck to the womb and it won't come out. And even those two problems are not there. Sometimes the uterus doesn't contract on its own. You lose blood very rapidly. Very rapidly. Approximate blood loss is estimated at about 500 cc in about 20 minutes. That's the fourth stage of labor. So all these things, the common result is bleeding. Let's talk about uterine inversion a little bit. It's a potentially life-threatening complication of childbirth. It happens after the baby is born, and everybody thinks, oh, wow, the baby came out, we're all very happy. And it is when the placenta does not detach from the uterus. It's commonly called the stuck placenta. And either it comes out on its own or people pull on the cord, which is something we all do to kind of get the placenta to come out. And instead, it pulls the uterus out. And if you look at these pictures, you can see the umbilical cord there with an arrow in picture number 1. And if you place it backwards, you see that little red patch. That's the placenta. And in this particular case, it's attached to the very top of the uterus. In the middle picture, you see it has inverted itself, it's come out halfway, and in the third picture, the whole thing has come out. The uterus is inside out. And when it happens, when it is coming out like this, and you see, sorry that I'm coming this way, and you look at this gap here. Remember, your intestines and all that are all here. Sometimes the intestines get pulled in there, and that causes a lot of parasympathetic reactions on the part of the mother. She becomes hypotensive, she becomes diuretic, she becomes this, and then everything falls apart. And all because this thing turns inside out. Now, to put it back in, there are special techniques. You can't just push it in. This doesn't go back. there are special techniques to push it back in. You'll only make it worse if you just try to shove it back in. It doesn't work that way. Alright, these are the signs and symptoms that something is not happening. The placenta doesn't come out, and yet you can't find the fundus here. It seems to be low. If you look at that tension, there's not much bleeding maybe, because the placenta hasn't separated. Sudden collapse. The mother is suddenly in shock, and is most able to have a sympathetic reaction, and not necessarily due to shock from blood loss. Most common reasons: putting too much of fundal pressure, overzealous cord traction, congenital weakness of the uterus. Sometimes the uterus has got built-in walls. Sometimes if the labor is very, very rapid. Uterine weakness in terms of overstretch. If the uterus has got too big, too stretched, the placenta has the decidua has eaten into the muscle quite a bit. And it's more common in multiple gestation. Supposing we have used magnesium sulfate, let's say to prevent eclampsia or to manage preeclampsia, that makes the uterus get a little bit weak too, because it doesn't contract as well. So those things are things that might help the situation. Now the next most important thing is in terms of bleeding, where the placenta is stuck to the uterus. You can see in this picture there are 3 different stages of placenta. This is normal. This is normal. That's normal. That's a little bit. That's a whole lot. Where the placenta is eaten into the uterus, so it won't separate. There are techniques to make it separate, but unfortunately sometimes you have to do surgery. It's interesting that you can leave the placenta intact after birth and let it shrivel itself up, sometimes 2 weeks, 3 weeks, 4 weeks later, and it might separate. There is no rule that says you have to push the placenta out. We have learned that over the years. It's kind of a risky thing in a way, but it can be handled. A lot of antibiotics, the mother should be monitored very carefully. But if you try to go and just yank it out, you only do it partly. A stuck placenta. There are 3 levels of getting stuck. Now this is the most common and fatal postpartum complication worldwide. When you talk about mothers dying in foreign countries in large numbers, this is it, that causes it. After the baby is born, usually with mismanaged long labors, the uterus fails to contract rapidly after the placenta is delivered. It is a mushy ball of meat. It's not firm. It doesn't do that. So you just keep losing blood. And in most home settings and in out of the way places, there is no blood displacement. So profuse bleeding. It can happen after a cesarean section too. It might even happen a couple of days later. And it's usually because of an overstretched entire uterus. Most of the time, if the uterus is infected because of long labor, very difficult to make it grow. Alright, so you have to have a lot of IV access lines. Okay, nipple stimulation and breast feeding are very important. Immediately after birth, if you stimulate the nipples, the uterus begins to contract a little bit. So those little maneuvers help to maybe improve the situation a little bit. Manual massage is also important. Emptying the bladder is also important. And we have medications now that can make the uterus contract very strong. The oxytocin and prostaglandins. Now we have other devices like packing devices. You can pack the uterus with various things. Those are all temporary measures, not used very much nowadays, but the balloon devices are much better compared to what they did in the old days where they packed it with cloth. Nowadays we can do something like a large Foley catheter kind of thing into the uterus and pump it full of air and it will expand and fill the uterus up. Okay. And of course, if all that fails, you can ligate the uterine arteries or you can embolize the uterine arteries. Now, in this way, you preserve the uterus for future childbearing. That's why you do things. But supposing the mother already has had 5 or 6 children and she doesn't want any more, then maybe this is not necessary. You can do a hysterectomy, which is much faster and safer. There's something that I want to talk to you at the very end here. I'm talking about placental abruptions, which is where the placenta separates from the uterine wall before the baby is born. I will not get into that, but I want to talk about something that is a little bit more controversial and maybe not heard of in Sri Lanka very much. Forgive me, I was going to go through all of this in 45 minutes. Remember, we have to buy time in hematologic emergencies. Okay? So you have to be suspicious of diagnosis, make arrangements for transport, preterm shock with oxygen, have large for IV vessels. If one of it is done in the meantime, correct coagulopathy is necessary. Here's the thing called the use of the G-suit. I was talking to Dr. Nihal, and I was not quite aware of what it was. A G-suit is a way of getting maximum use of the mother's blood. Okay? In the sense, the blood that she already has in the body. Here it is. If you look at this, it looks like it's got a lot of blood pressure puffs along the body, all over the place. And you can inflate these things to very high pressures. And whatever blood there is in the extremities will get squeezed centrally, and you'll keep the core organs in circulation until you have more blood to fill her up again. So I have used this a couple of times. It's called the G-suit because it was originally invented to prevent people passing out when they are going into space. The amount of gravity pull as they are getting out of the atmosphere is so great that their blood pools in their legs and they pass out. So they invented this suit and now they are using it to prevent maternal shock. Okay. Now, post-mortem and peri-mortem cesarean delivery. This is where you do a cesarean section on the mother after she is dead. Why? Because the baby is yet alive. It's a little bit controversial, but in modern life, there are lots of opportunities or situations where we have to do it. Okay, gunshot wound deaths, traffic accidents, suicides, and preeclampsia, where the mother dies very fast and the baby is yet alive. It's usually done in the accident ward or the emergency room or even in the ambulance. Okay? And while they're doing it, CPR may be in progress because they might think the mother has a chance. And also to do CPR, sometimes it's not easy because the pregnant uterus is getting in the way. So it's done without any anesthesia, there is no consent that is taken, and you have to have good clinical judgment as to how old the fetus is. You wouldn't do this on a fetus that's 28 weeks or 26 weeks or 30 weeks. You should be almost sure that it's like maybe over 35 or 36 weeks. They have figured out that about 10 to 15 minutes after the mother dies, the fetus will be like injured to the point of no recovery. But within 5 to 7 minutes, it's almost like 100% recovery. So they have now stretched it to about 10 to 15 minutes. And you have to have an adequate neonatal unit for the baby to be looked after. Now there are some medical legal issues in this, but in most states the Good Samaritan laws protect it. All right, thank you for listening. I'm sorry I didn't give you a full dose of my talk because I have no time. Thank you very much.
Thank you very much, Dr. Nihal. Please